Hello. Now I'd like to speak to you about thermal injuries. In other words, it's time to talk about burns. Burns can be divided into first degree, second degree, and third degree most commonly. First degree burn, that's sunburn. Skin gets a little red and then peels as it heals later that week. Second degree burn is the blister. The top layer of skin is denuded or a blister forms. A third degree burn refers to skin that is leathery and charred without any pain. Some people use the phrase fourth degree burn, and this refers to severe injuries where not only is the skin destroyed, but so is the subcutaneous tissue, the muscle, and what just left is exposed bone and the deeper structures. Burns are graded first, second, and third most commonly. Remembering the pathophysiology of burns is important. There is the zone of coagulation, the zone of stagnation, and the zone of hyperemia. The zone of coagulation, that tissue is dead. It's never coming back to life. The zone of hyperemia, of increased blood flow, that area has excellent blood flow and will live. Your treatment determines if the zone of stagnation will live or die. This is an area where the blood flow is very sluggish through the tissue. With proper treatment, the zone of stagnation will live and the patient will have a much less deep burn. It will be more superficial. If the burn is not carefully cared for and either infection sets in, or if you put ice on skin that's been burnt and you give frostbite and you kill the zone of stagnation, the burn will be deeper. And this is important because if you make the burn deeper, you may convert a burn that just needed antibiotics and time to heal into a burn that's going to require extensive skin grafting and surgical procedures. So the care of the burn is important. Here is another way to look at burns. And in this classification scheme, the second degree burns are separated into second degree superficial and second degree deep burns. And this is somewhat important because these two types of burns are treated differently. The second degree superficial burn, that's the blistered skin, and it's very red, and it's very moist and very painful. It involves primarily the upper papillary dermis. Typically this is your hot coffee burn, spill hot coffee on yourself. And it takes 2-3 weeks with some antibiotic salve for it to heal on its own spontaneously. A second degree deep burn, these are drier. They're not as moist. They're not beefy bright red, there may be a little white color to them. And this involves the deeper reticular dermis. They're often from things that hold a lot of heat in them, like steam is a devastating burn because it holds so much thermal energy, or from hot glue. And left on their own, these will take 2 months to heal, and it won't be the best scar. Second degree deep burns generally require skin grafts. Second degree superficial burns generally require just the antibiotic salve and the skin will heal fine on its own. Third degree burns, again, that's the charred, leathery burn where it has no feeling in the burn. It's anesthetic. All the dermis is destroyed. These are from things such as open flame and from hot oil, grease fires. And these burns need debridement and skin grafting. Here's a picture of a horribly burned child who would have to go to the burn unit. Burns come in many different from many different causes. Most commonly there's thermal burns. Don't forget that radiation can cause burns, as well as chemical and electrical injuries as well. Do you remember the rule of nines to estimate the size of coverage of burns? Okay. The palm of the hand is approximately 1% body surface area. The head is 9%. The anterior torso, from the neck to the inguinal fold, to the mid-axillary line, that's 18% total body surface area. The posterior torso is 18%. An entire arm is 9%. An entire leg is 18%. And that should add up to 99. The last 1% is reserved for genitals. And you know what? This is just an approximation to give you an idea of how much the patient is burned. Patients who are burned need a lot of fluid resuscitation. They need saline or Ringer's lactate. And the Parkland formula is the traditional way to estimate the fluid requirements over the first 24 hours since the patient received the injury. Okay? To do the Parkland formula, the total fluids for the first day is the weight of the patient in kilograms times 4 times the total body surface area burned. Okay? You give half of that number, of that volume, in the first 8 hours since the injury occurred, and the second half of that volume in the remaining 16 hours. Lactated Ringer's is a great choice of fluid. The Parkland formula should be remembered as just an estimate. It was developed because traditionally doctors underestimated the severe fluid and electrolyte shifts that occurs in major burns, and patients were becoming hypovolemic and under-resuscitated. Still use your traditional parameters of mental status, vital signs, capillary refill, urinary output to determine if the patient might need even more fluid than the Parkland formula suggests. Here are some things you shouldn't do for burns. Don't put ice on burns. After the burning has stopped, let's take an example of someone that spills hot coffee on their lap. It's very tempting to put ice on. But the burning action has stopped a long time ago, and now the patient's just in pain. So a better choice would be to give the patient oral or parenteral narcotics to control the pain. Putting ice on the burn only decreases the viability of that zone of stagnation and has the possibility of making a second-degree superficial burn into a second-degree deep burn, which would then require skin grafts. Parenteral antibiotics, giving cephalosporins parenterally is not correct. You do not give patients IV or PO parenteral antibiotics when they are burnt. You only give those antibiotics if they later develop sepsis or cellulitis. You do give topical antibiotics for small burns to help prevent infection. Sulfasilvadiazine is a common example. Any topical antibiotic will work. The only time I don't put on topical antibiotics onto burns is if they're going to the burn unit. If a patient's going to be transferred to a burn unit, the first thing the burn unit's going to do is remove all the antibiotic cream that you put on the patient. And that's going to be a painful process. The burn unit wants to look at the burn themselves to decide its depth. Steroids are not given prophylactically for burn patients. Okay? They're only given as needed later. Who goes to the burn unit? Well, the criteria are slightly different from burn unit to burn unit, but as a general rule, if an adult patient receives a 20% total body surface area burn, you're a candidate for the burn unit. Okay? If you're very young or very old, even burning just an entire arm, 10% burn, that's enough to absolutely need the burn unit. Severe burns of the face or the hands or the perineum also require special care to prevent any contractions. And certainly patients that receive burns of the pulmonary tree or electrical or chemical burns which are severe in nature often have much destruction of tissue and would benefit from the expertise of the burn unit. Third-degree burns, even as little as 5% total body surface area that's going to need skin grafting, is a good reason to call your regional burn unit and ask if they would like to accept the patient. Okay, let's talk about pulmonary inhalation injury a little bit. Here's a case of a 47-year-old fireman putting out a forest fire and a burning tree fell near him. He has a burn of his left arm. So that means that he has a 9% total body surface area burn. This particular patient has no soot in his mouth or nose. He's not coughing. He has no hoarseness. He has clear lungs. His chest X-ray is normal. Question number 1. How much lactated Ringer's does he need in the next 7 hours? Well, if he is 100 kilograms and he has a 10% body burn, that's 1,000, times 4 is 4,000 cc's at least over the next day. So he needs approximately 2,000 cc's, or 2 liters, over the first 8 hours since his injury. So the answer is he needs at least 2 liters. Okay? If you start giving him this fluid and you realize that he has no urine output after an hour or 2, that does not mean you should only stick to what the Parkland formula says. Go ahead and give additional fluid boluses until the patient's adequately resuscitated. The next thing to consider is, does this man have carbon monoxide poisoning? Well, certainly anyone who's exposed to any fire at all, you'll have a low threshold to go ahead and order the carbon monoxide level and find out. The last issue is, does he have a pulmonary injury, an inhalation injury of heat? Patients with an inhalation injury often have singed nasal hair. They have a cough productive of carbonaceous sputum. They may start to have stridor from laryngeal edema. They may have rales, rhonchi, and wheezes on the lung exam. And they may have an abnormal chest X-ray. This person has none of those symptoms. The other factor that speaks against him having a pulmonary injury is the fact that it occurred outside. People that are in house fires in enclosed spaces tends to keep the heat, tends to be hotter and have the heat go into the patient's lungs. Now, you might argue that, hey, forest fires are devastating and the canopy is burning above him. If you have any concern that there might be the slightest hint of a pulmonary injury, this patient needs bronchoscopy, pulmonary bronchoscopy, to look at the lining of the trachea and major bronchi and determine if there's any pulmonary injury. A wait-and-see attitude if you suspect pulmonary inhalation injury is wrong. You want to know the diagnosis immediately. Why do you want to know the diagnosis immediately if you have a heat injury to the trachea and bronchi? It's because over the course of the next several hours, there's going to be more edema and more swelling, and soon it will be nearly impossible to intubate and ventilate the patient. So certainly, if you have a similar case of someone trapped inside a burning house, and they have all the signs of pulmonary injury, they have singed nasal hair, there's soot in the back of their throat, they're coughing up soot, they're short of breath, they have abnormal chest X-ray, they're stridorous. That person needs to be intubated immediately, right now, because the situation is only going to get a lot worse before it gets better. Okay? So to summarize, pulmonary burns. If there's no possible way they had a pulmonary inhalation injury and they have no signs and symptoms, you don't need any bronchoscopy. If they have signs and symptoms clinically of a pulmonary burn, they just need to be intubated now. And if they have a burn which you suspect may have caused pulmonary injury, but there's no signs or symptoms yet, they need immediate pulmonary bronchoscopy to be absolutely sure. Here is the case of a person trapped in the house who's coughing up soot and is starting to get stridorous. Intubate now. You don't need bronchoscopy. All these people who you suspect have pulmonary injury, of course, will be admitted to the hospital, to the intensive care unit. Next, I'd like to speak to you about heat disorders other things that may cause high fever but not burns. The exertional heat disorders include heat cramps, heat exhaustion, and heat stroke. Other conditions that cause high fever are malignant hyperthermia and neuroleptic malignant syndrome. So if these 5 disorders, heat stroke, malignant hyperthermia, and neuroleptic malignant, all cause high fever, heat cramps and heat exhaustion do not cause a very elevated fever. Now, if someone has a high fever, of course we think of sepsis as the most likely cause, and it almost always is. But in addition, consider other things that cause fever would be thyroid storm from hyperthyroidism, anything like status epilepticus, where there's a lot of shaking and production of heat from the skeletal muscles. We had aspirin toxicity earlier as a cause of fever. Don't forget delirium tremens from alcohol withdrawal. Don't forget disorders that cause an inability to release heat from the skin, such as scleroderma. And other drugs predisposed to hyperthermia, such as phenothiazines, some pathomimetics, and anticholinergic toxicity, which we discussed earlier. So exertional heat disorders, there will always be in the question, the patient was out and exercising, doing some physical activity. So the 3 diagnoses you can have are heat cramps, heat exhaustion, and heat stroke. The first 2, heat cramps and heat exhaustion, are not particularly dangerous. Okay? Heat stroke is fatal unless you treat it appropriately and quickly. Okay? Heat cramps, let's take that first. That's those crampy feelings you get in your legs when you've been out exercising on a warm day. Your vital signs will be normal. Your temperature will be normal, within normal limits, normal. Your mental status will be normal, and you'll still be sweating. You will be sweating. Heat exhaustion is a little more advanced. The temperature is normal or maybe slightly elevated, 101. Okay. The mental status is normal, although the patient may complain of being tired, being nauseous. Occasionally will be a little dizzy or lightheaded. You can actually have some vomiting with this. The patient feels exhausted. Overexertion on a hot day without adequate cooling and adequate fluid replacement. The treatment for these first 2 disorders is simply get out of the heat, go into the air conditioning, and drink some cool fluids, and you'll be fine. Occasionally, you'll meet someone with heat exhaustion that feels so nauseous and is so dehydrated that they receive intravenous fluids for a couple of hours until they feel better and go home. These patients go home. Heat stroke is a totally different animal. These people have temperature above 40 degrees Celsius, that's above 104 Fahrenheit, and have markedly decreased mental status. Okay? Okay? They are dry. They are not sweating. The compensatory mechanisms that prevent heat stroke, namely sweating, have been overwhelmed. So the temperature goes up rapidly. Brain is cooking. Heat exhaustion, heat cramps, sweaty. Heat stroke, no sweating. So heat stroke's a medical emergency. How are we going to treat these patients? Heat stroke, you need to get the temperature down as rapidly as you can. All right? And the best way to do this is to get the patient naked, get them wet, get their hair all wet, get their skin all wet, and put a big fan on them. And this will cool them down most rapidly. It's the same principle as stepping out of the shower when you're wet. You feel cold right away? Why? Because water is taking the heat out of your body, and it's evaporating and carrying it away, and you feel cold. Okay? So if you get patients wet and then put a fan on them, you'll evaporate the water and pull all the heat off the patient. It's important to do it rapidly because the patient's going to have brain damage, going to have seizures, going to have rhabdomyolysis, some muscle breakdown, disseminated intravascular coagulation, acidosis, and ultimately collapse of their cardiovascular system and death. All right? So get them undressed, wet them down, and a big fan. The patients are routinely going to be dehydrated and need intravenous fluids. If the patient starts to shiver, well, take their temperature. Once you get the temperature down to about 102, you can back off on the big fan that's cooling the patient. But I do want to prevent shivering in these patients. Why? Well, because you shiver, you're making more heat. Skeletal muscle contraction and shivering makes the temperature go up. So to block the shivering response, don't use aspirin. To block the shivering response in heat stroke, use benzodiazepine or chlorpromazine. What don't we do in heat stroke? Well, we don't use any ice saline in the IV fluid. Why? Can you take a central line and infuse 36 degree Fahrenheit water rapidly into the heart? Is that a good idea? The answer is no, because you could stop the patient's heart. Okay, so no ice saline in the IV. Similarly, we don't immerse the patient in an ice water bath. Too painful. And aspirin is contraindicated in this situation. Aspirin, as you know, toxicity can cause fever itself. Now, a couple other things that cause high fever is malignant hyperthermia. And malignant hyperthermia is really easy to diagnose because the patient just had anesthesia today, within the last couple of hours. If the patient just didn't have general anesthesia, they don't have malignant hyperthermia. It's that easy. Any agent can do it: halothane, isoflurane, enflurane, succinylcholine. It is an autosomal dominant condition due to the reuptake of calcium at the sarcoplasmic reticulum. All right? And they're going to get high fever, rigidity, rhabdomyolysis, tachycardia, followed by acidosis and hypotension. All right? The treatment for this is dantrolene. Dantrolene. The anesthesiologists often carry it around with them in case they ever get a case of malignant hyperthermia. They're prepared. This is why they're always taking the family history of problems from anesthesia before you have an operation. They're looking for this condition. Neuroleptic malignant syndrome looks similar. You have the high fever and the rigidity, which leads to rhabdomyolysis and the lactic acidosis. And the key to looking for this is the patient has to be on a neuroleptic drug. All right? Usually started in the last month or two. All right? So the classic thing to do it is Haldol or Navane. But other things have neuroleptic properties such as Reglan or tricyclics, even lithium and monoamine oxidase inhibitors, MAOs, have been implicated. If you have a neuroleptic malignant syndrome, you diagnose that with the absence of sepsis, someone with a high fever and rigidity on one of these medications, and you treat with bromocriptine or dantrolene. Bromocriptine or dantrolene to help. Okay? So here again, neuroleptic malignant syndrome, malignant hyperthermia, they all look the same. Hyperthermia, comatose, altered mental status, rigid, diaphoretic. There are other things that cause high fever, and we touched on them briefly. Meningoencephalitis, general sepsis, thyroid storm, delirium tremens, alcohol withdrawal, anticholinergic poisoning. Serotonin syndrome looks very much the same. It consists of someone that's jittery, febrile, rigid, tachypnic, hypertensive, tachycardic, leading to muscle breakdown, DIC, rhabdomyolysis, electrolyte disorder, and dehydration. Okay, so to review, neuroleptic malignant syndrome, how do you treat that? Stop the drug that's causing it. Supportive care, ABCs like everybody, bromocriptine, dantrolene. Here's more on the serotonin syndrome. Serotonin syndrome occurs most commonly when the dose of the SSRI has been increased recently. And they can present with rigidity, clonus, change in mental status. They'll be febrile, they'll be diaphoretic, they'll be agitated. So in these particular patients, benzodiazepines are also a good choice because it decreases the muscle spasm. When the temperature gets up to 105, 106, they may need to be intubated due to the severity of their illness. And as a last resort, paralysis, so their muscle paralysis chemically through anesthesia can prevent any more muscle breakdown and rhabdomyolysis. Next is hypothermia. And hypothermia is most associated with alcohol. Patients that are intoxicated and outside and don't realize they're getting cold because of the vasodilatory properties of alcohol, and by that I mean ethanol, beer, wine, and whiskey, frequently are the ones that end up hypothermic. Hypothermia is described as a temperature less than 95 degrees Fahrenheit. Okay? So the first problem with hypothermia is making the diagnosis. And you'll say, well, that's easy, just take the temperature. But many thermometers only go down to about 94 or 95. So if you get a reading of 94 or 95, you have to get what's called a rectal probe, which gives you a better indication of the body's core temperature. Okay? They also make Foley catheters. They have thermometers on them, and you can get a core temperature that way. How do we lose heat? Well, remember your physics. It's conduction, convection, radiation, and evaporation. Conduction is the direct contact. When you touch metal and it's cold, the heat goes directly into the metal. Convection is wind. Radiation is like a light bulb. And evaporation we talked about. We use evaporation to treat the hyperthermic patient. All right? So when you think hypothermia, you're going to check an ethanol level, ETOH, because that's most commonly the problem. But other patients get hypothermic as well. Who else would get hypothermic? A common one is hypoglycemia. Patients who are in insulin shock or have a blood sugar of 20 all night, when they're found unresponsive in the morning and given D50, often wake up shivering because their body temperature has dropped due to the hypoglycemia. Hypothermia is also common with hypothyroidism, hypoadrenalism, and hypopituitarianism. Stroke can also cause hypothermia if there's an alteration, any alteration of the hypothalamus. All right? Not everybody with sepsis gets a fever. Especially neonates are famous for having hypothermia of sepsis, and this occurs in the elderly as well. They have sepsis, they're infected, and they're hypothermic. Of course, our patients with burns, who have all this exposed wet skin from their second-degree burn, these patients very easily get hypothermic, and burn patients should be kept warm. So how do they grade hypothermia? Mild, moderate, severe. Mild hypothermia, the patients are shivering. That's from about 32 degrees Celsius up. All right? They might be a little ataxic. They might have a bad judgment. They might appear apathetic. But the main issue is that they're still shivering. In other words, their ability to generate their own heat is still intact. So all you have to do for these people is get them out of the cold environment, get them out of their wet clothes and dry them off, and give them a warm blanket, and their own shivering will bring their body temperature back up to normal. Patients with moderate or severe hypothermia, these patients are in big trouble because they're not shivering. Their protective mechanisms to make their own heat has failed. They may appear very stuporous to frankly unresponsive, and as their temperature goes down, their EKG becomes more unstable with lengthening of the PR interval, lengthening of the QRS interval, lengthening of all the intervals, and they become bradycardic and have respiratory depression as well. Patients with severe hypothermia might appear dead. You know, they might appear apneic. They might appear pulseless. And patients with severe hypothermia are very susceptible to ventricular fibrillation. But the old saying goes, no one's dead until they're warm and dead. Patients with even a very infrequent pulse or infrequent respiratory effort can still be resuscitated. So if someone is found in this condition, you need to warm them up before pronouncing them dead. The EKG changes with hypothermia, right? The T waves change, the PR, QRS, QT intervals all get wide. The heart rate slows. Here's a picture of an Osborn wave. Look especially in the V4, that's V5, V6. That's a nice example. It kind of looks like a right bundle branch block pattern, doesn't it? But the second rabbit ear has this bizarre configuration. This is the Osborn wave and is seen with hypothermia. So if you got an EKG like this, you're thinking, hey, I better take their temperature. There's two types of rewarming for hypothermia. There's passive rewarming and there's active rewarming. Passive rewarming means getting the patient out of their wet clothes, dry them off, get them into a warm environment, let them shiver, give them a warm blanket, and you're done. If you want to look for something, look for ethanol intoxication, alcohol intoxication, look for hypoglycemia. Occasionally you'll find someone with an infection. I would look for medical alert tags. If the patient has hypoadrenalism, perhaps they need additional steroid. Okay? Active external rewarming includes the heating blankets, using warm water bottles filled with warm water placed in the axilla and the groin to help rewarm the patient. There is a concern about a concept called core temperature after drop. And this means that even though the patient is generally warming up, if you warm up the extremities first and not where the heart is, some cool blood from the extremities could pour back into the central circulation and cause this core after drop phenomena where the temperature actually decreases first before it increases. To prevent this core after drop, the technique is to do some core rewarming or active core rewarming. And the easiest way to do this is with a heated aerosol. Like breathing a little warm mist, like a vaporizer, right? That will warm up the patient very quickly and is usually all that's needed. You can use warmed IV fluid, but be careful not to make the temperature too warm, as you don't want to coagulate the patient's blood. Just body temperature warmth, 98.6 is good. That'll warm up the patient with warm IV fluid. You can warm the patient up with a lot of messy procedures, such as lavage of the mediastinum, or peritoneal lavage, or lavaging the bladder, or putting warm water in the stomach and then aspirating it back out and putting more water right down. But if the patient is so hypothermic where they're nearly apneic or severely bradycardic, the quickest way to warm them up is to call the heart-lung bypass team and put them on extracorporeal bypass. This is the quickest way to warm the patient up and see if they have a heart rate. If they have no heart rate, the patient is dead. If they warm up and their heart rate picks up, you've saved a life. That concludes the discussion of hyperthermia and hypothermia.